Good afternoon, everyone. I'm Dr. J.P. Chug. With me is Dr. Vanati on my left and Dr. Poonam Kishore on right. May I request Dr. Patel and Dr. Dinesh if they are here. Please be on the dais. Okay. May I know who are the present here? Who of the presenters are there? Dr. Madhumita, there. Dr. Radhika, Dr. Sunandani, Dr. Pooja, Dr. Samrat, Dr. Prajapati, Dr. Krishan A. Prajapati is not here. Dr. Manjunath. Dr. Manjunath is also not here. Dr. Madhu. Yes, thank you. Dr. Pawan and Dr. Tushar, Dr. Dipali. She is also not here, and one Dr. Alok Ranjan. Right. So, okay. So we start the session, and time allotted is 6 minutes for each presenter. The first presentation is by Dr. Madhumita, Corneal Neural Imaging using in vivo confocal microscopy in cases of congenital corneal anesthesia. Dr. Madhumita. And next presenter may please be ready. Dr. Radhika.
Good afternoon. I have no financial interest to disclose. Congenital corneal anesthesia is a rare complex neurological disorder which can occur in isolation, involve all branches of the trigeminal nerve, or as a more universal congenital insensitivity to pain and anhidrosis. It usually presents between 8 to 12 months with poor vision, photophobia, conjunctival injection, and corneal ulceration, characteristically with the absence of pain and distress. It goes through the stages of an initial geographic dry spot formation, followed by an epithelial breakdown and stromal lysis, which can further go on to a corneal perforation. It is a challenging disease to diagnose, and it is often misdiagnosed, with the only effective treatment strategy being a lateral traceraphy. A number of studies have been done to theorize the etiopathogenesis of this disease. However, no studies have been done examining the architecture of the corneal nerves in these conditions. The normal corneal nerves are present as the stromal plexus and the subbasal plexus, with the subbasal plexus being thin and beaded. Up to recently, most of our knowledge of the corneal neural architecture was based on the examination of corneal buttons through light and electron microscope. However, due to the spontaneous autolysis of these nerves soon after death, much data was not available for us. This changed with confocal microscopy. Confocal microscopy provides us an optical section of the living cornea and allows a detailed evaluation of the living cornea both in its physiological and pathological states. This is a representative image of normal subraces nerves through in vivo confocal microscopy. A number of studies have been done on corneal nerve anatomy using in vivo confocal microscopy. However, no such studies have been done in cases of congenital corneal anesthesia. Therefore, our objective was the quantitative estimation and comparison of the corneal neural architecture using real-time in vivo confocal microscopy, particularly in patients with congenital corneal anesthesia, and comparing them to a control population. The study was conducted in Tej Kohli Cornea Institute. It was a prospective, non-consecutive, comparative interventional clinical case series. The study population included cases of congenital corneal anesthesia which fulfilled the inclusion criteria, and the controls were their unaffected siblings or parent. The inclusion and exclusion criteria were listed and adhered to. IRB approval was obtained and informed written consent taken. All patients underwent a comprehensive eye examination. Corneal neural imaging was done using the NIDEC Confo Scan 4. And these images were, of these images, 3 to 5 of the best images were randomized and analyzed. The architecture that was studied included the length and thickness of the corneal nerves, the dichotomous pattern, presence of beads, and the density of the nerves. These are sample images of the study of a case and a control. Statistical analysis was done, and all variables were found to be continuous. Those with normal distribution were analyzed using the student t-test and the others using the Mann-Whitney test. A p-value of 0.05 was taken as significant. 12 eyes of 8 cases and 16 eyes of 8 controls were analyzed. It was noted on the analysis of the dichotomous pattern that the median in the controls was 82% as compared to 45% in the cases. Although there was a marginally overlapping interquartile range, the p-value was found to be 0.1. On analysis of the length, breadth, and density, it was found that the density of the corneal nerves was significantly lower in cases as compared to controls, with a mean of 4.11 compared to 6.52 millimeters per square millimeter. The p-value was found to be 0.007. From this study, we see that there is a significant reduction in the density of nerves in cases of CCA as compared to a normal population. There is also a noticeable difference in the presence of dichotomous pattern of the nerves. Therefore, there is a correlation between the functional loss, that is the absent corneal sensation, and the anatomical decrease, that is the reduced subbasal nerve density of corneal nerves in cases of congenital corneal anesthesia. And although the sample size was small, considering the rarity of the disease, these findings can be considered as relevant. Thank you.
Just a minute, Dr. Madhumita. How did you suspect this corneal anesthesia? How did you suspect it in your
These
patients?
were children who had no senses, as in there was decreased cheering. They had on putting any drops into their eyes, they had no reflex blinking, no irritation. In children especially, there's a lot of resistance that we usually see when we try to examine them or put drops in them. This wasn't there in these patients.
Okay. And what was the usual age group that you found in your study?
The patients were diagnosed earlier on, but the study was done for cooperative patients, so that was above 8 years old.
Mm-hmm. Okay.
So next is Dr. Radhika. Newer parameters for early keratoconus diagnosis on anterior segment OCT.
Good afternoon, everyone. I am Radhika Dashputra. I am third year resident at Guru Nanak Eye Center, and I will be presenting newer parameters for early keratoconus diagnosis on anterior segment optical coherence tomography. As we all know, keratoconus is a progressive disorder characterized by central paracentral corneal stromal thinning. Diagnosis of manifest cases of keratoconus is based typically on slit lamp examination and topographic findings. However, early diagnosis continues to remain a challenge. Role of epithelial mapping has been explored by many recent studies. In 2010, Reinstein et al. Used very high frequency ultrasound to describe a localized central zone of thinning surrounded by an annulus of thickened epithelium, which they called as donut pattern. Yanli et al. Have conducted multiple studies in OCT-guided epithelial mapping, and they proposed epithelial asymmetry and thinning in the area of cone as an early marker for diagnosis. In 2015, Reinstein et al. Timstead et al. Proposed a diagnostic threshold of 52 microns for minimum epithelial thickness for diagnosing firm thrust cases. However, a study by Sandali et al. In 2013 found epithelial thickening in the area of cone in advanced cases. This uncertainty in the nature of epithelial compensation led us to conduct a study to analyze AIOC2018 corneal, pachymetric, and epithelial pattern in different stages of keratoconus and to determine its supplemental role in early keratoconus diagnosis. It was a prospective cross-sectional study with 5% level of significance and 95% power. 100 eyes of keratoconic subjects in the age group of 7 to 25 years were recruited for the study. Normal eyes were also taken as controls. Patients with advanced disease and corneal scarring were excluded from the study. All the subjects underwent detailed ophthalmic examination, including slit lamp examination and topography. AIOC2018 pachymetric and epithelial mapping was done using a commercially available software. The parameters that were considered in pachymetry for further evaluation were pachymetric difference between the superonasal and inferotemporal quadrants, superior-inferior difference, minimum pachymetry, location of minimum pachymetry along y-axis, minimum median difference, and in epithelial parameters, minimum epithelial thickness at the minimum pachymetry, and standard deviation of epithelial thickness and zonal thickness in superior, central, and inferior quadrants. These are the results of our study. The subjects were distributed in different grades of keratoconus according to the Amsler-Krumig classification, and fellow eyes of unilateral disease were labeled as firm thrust according to the definition proposed by Amsler. In the pachymetric analysis, the minimum pachymetry showed a decreasing trend with increasing stages of keratoconus, which is a well-established fact. However, other pachymetric variables did not show a specific trend. In epithelial thickness mapping, there was a significant difference between groups in minimum epithelial thickness and epithelial thickness at minimum pachymetry without a specific trend. The standard deviation of epithelial thickness, which points towards epithelial asymmetry, showed an increasing trend with advancing grades of keratoconus. To determine the diagnostic accuracy of these parameters, we conducted a ROC curve analysis. The superonasal inferotemporal pachymetric difference and the standard deviation of epithelial thickness had good area under the curve with clinically significant cutoff values obtained using the Jordan's index. Using a cutoff value of 32 micron for superonasal inferotemporal pachymetric difference, keratoconus could be diagnosed with 75% sensitivity and 80% specificity, and a cutoff value of 2.5 for epithelial thickness standard deviation diagnosed keratoconus with 77% sensitivity and 84% specificity. I would now like to briefly run you through a few of our representative cases. This is a 20-year-old male who was diagnosed with stage 2 keratoconus in his left eye. This is the Scheimpflug topographic image of his right eye. Seen in isolation, it appears to be within normal limits. The enhanced ectasia display also does not show any hotspots. However, the AIOC2018 pachymetric and epithelial mapping shows that the superonasal inferotemporal pachymetric difference and the standard deviation of epithelial thickness is elevated above the diagnostic cutoffs, which would make one immediately suspicious. This is a 24-year-old male with grade 1 keratoconus. On epithelial mapping, we see what has been typically described as a epithelial donut pattern, area of thinning surrounded by an annulus of thickened epithelium. In conclusion, I would like to reiterate the two diagnostic thresholds, superonasal inferotemporal pachymetric difference of 32 micron and standard deviation of epithelial thickness more than 2.5 as a screening tool for early diagnosis, warranting further evaluation and a closer follow-up. Thank you.
Did you observe any relation between the epithelial thickness and corneal thickness?
So not specifically, but there was a generalized trend towards decrease in both of them with advancing grades of keratoconus.
Yeah, nice paper. When you compared the diagnostic criteria using epithelial thickness mapping vis-a-vis what we commonly follow on topographic criteria, were the percentages of your classifications different the various grades, or you did not find any difference?
No, that was not analyzed, ma'am. Only a dichotomous variable for ROC analysis was taken as either control or the
So
keratoconus.
not part of your methodology.
No, not part of my methodology.
Thank you.
Thank you for your consideration.
Next speaker is Dr. Sunandani, and our topic is an innovative technique of graft preparation in PUK using a novel pick and print technique.
A very good afternoon, everybody. Today we'll see a paper on the innovative technique of graft preparation in peripheral ulcerative keratitis using the novel prick and print technique. Now, these peripheral ulcerative keratitis are usually characterized by the crescentic shaped destructive inflammation with various degrees of limbal involvement, and it often causes perforation also. So what modes of keratoplasty do we have for them are the large circuloeccentric graft, but these are more prone for rejection, and also the sutures might come into the optical axis. While the smaller grafts have lesser chances for this, but these also have limited use. So this is the reason why we needed to modify the shape of the corneal graft. So we did a biconvex graft like this, or a crescentic graft showing like this. So fashioning this kind of grafts were quite difficult, and various techniques of freehand graft dissections and the use of corneal trephines have been used. So we present a novel prick and print technique for the construction of non-circular grafts of desired shape and size in conditions like PUK. So it was a retrospective design with 15 eyes of 13 patients from January 2013 to March 2017 in Sadguru Netra Chikitsalaya, Chitrakoot. Perforated PUK and non-healing PUK patients were taken with a minimum follow-up of 3 months. The primary outcome were the graft apposition tectonic integrity, intraoperative complications, while the secondary outcome were the visual acuity and postoperative complication. Showing you a small surgical video for the same. Here, what we are doing in after peritomy, we are marking the outline of the diseased cornea. After that, a thin plastic sheet is applied over the tissue and pricking along the mark is performed. Now, longitudinal stroke lines are performed just outside the cut. We are applying it over the donor and the ink is applied over the cut. Now we'll see the imprint in this, and the partial cut is performed with the excision of the donor. Then we are performing the excision of the donor cornea, and finally the suturing. So this, coming to the result, this study had a mean follow-up of 10.7 months with 14 eyes who underwent penetrating keratoplasty and 2 patients who underwent conjunctival resection before keratoplasty. In this table, what I want to show is that there were 10 patients who underwent crescentic graft, and they were mostly where there were more number of clock hours involvement. Intraoperatively, there was no overriding of any graft, there was no tissue gaping or flattening notice, all sutures were of proper length and depth, and there was a good graft-host junction apposition. Although in one patient, the diseased cornea got a little more excised, and there was a small shortening of the graft. Post-operatively, anatomical integrity, limbar architecture and corneal contour is well maintained as seen in this picture with a 3-month post-op, and all patients had a well-formed anterior chamber with no leak as seen in this picture of first day post-op. Visual acuity of better was there in 9 patients and 4 had worsening. Out of this 4, one patient had undergone a cataract surgery. One patient developed a PUK at other side than the graft. Another patient developed a PUK just adjacent to the corneal graft, and for which a patch graft was performed. This also started melting, so we performed a TPK for this. Coming to the discussion, the various measures that were there to control the diseases were the adhesive, conjunctival resection, conjunctival flaps, but amniotic membrane grafting and the various other non-biological techniques, but often they were of limited use. So the small round eccentric graft came into fashion, but this is also inadequate to cover the entire lesion once there is extensive limbal involvement. So modifying was the best possible way. So biconvex grafts were preferred over because of the shorter limbal length, and the crescentic grafts are best reserved for long furrow ulcers. So when we compare our study with others, we can see that the other authors have only performed the biconvex and the crescentic shape, where we were able to perform the comma and a semicircle shape using the same prick and print technique. The other authors have used the various corneal trephines for markings with similar post-operative results. In our study, we had a better visual acuity in 9 patients. Here what I want to show you is that even though the graft got edematous after few months, still the BCV of 6/6 was preserved. And the same technique could be used for even a more than 180-degree limbal involvement and for a shorter limbal involvement too. Here in this patient, what I want to show is that this patient underwent a glue BCL and a conjugal resection. Still, we had to perform a keratoplasty in this. So if this graft again becomes failed, so the patient still have a central corneal vision, which will be of attainable visual acuity. So the advantages of this study was to non-involvement of the optical center of the cornea, preservation of visual acuity even if the graft fails. So we are marking the exact ulcer on the surface. So the exact shape and size of the graft will be there without any disparity. The repeatability is good, it is cost effective or economical and can be performed by beginners. The few limitations were the short follow-up, unavailability of corneal topography in some patients. What we would suggest is that this is better performed at least of 180-degree limbal involvement. But if we use a better stencil material which is more transparent and can be fixed over to the cornea, like a bandage contact lens, it will be a better use. Thank you.
Why do you call it a retrospective study? I think this was a prospective interventional
Actually,
one.
ma'am, the study started before we started to, the design was because we collected the patient detail from a longer period of time. And when we collected the details, the patients, the surgery was already done in the patients. It was not a prospective. We did not perform the surgeries after we started this. The study, the surgery was already performed in the patients.
All right. And in the ones where the graft was going right up to the sclera, later on, did you get vascularization of that graft or no?
No, ma'am. In all the patients, we were using immunosuppressive therapies. And in some patients, we did a congenital resection more than once. So in few patients where yes, ma'am.
So next presenter is Dr. Pooja. Novel expression markers and its regulation using topical eye drops for corneal haze.
So good afternoon. I'm going to present our research topic on understanding various haze pathways and using a topical novel eye drop for controlling the same. At the outset, none of the authors have any financial disclosures to make. PRK is one of the most promising procedure when it comes to refractive error correction. However, it has its own few drawbacks, the most dreaded one being haze. MMC is known to prevent haze, but MMC has its own side effects and it doesn't work at times. So the aim of our study was to know what are the factors and the pathways which is driving haze, and can there be a novel targeted approach used to prevent this haze. It was a prospective study in which we included 110 eyes of 55 patients undergoing PRK surgery with a strict inclusion and exclusion criteria what we follow for our refractive surgery patients. Our model included collecting epithelium during the PRK surgery procedure and storing it in a biorepository at -80 degrees Celsius with a prior ethics committee and patient approval. After a few months, 6 eyes developed haze. So we went back to the biorepository, took those 6 epitheliums along with 10 eyes which did not develop haze and studied them for quantitative polymerase chain reaction to study the deregulated pathways. What we found was that in the pre-existing surgery epithelium of these patients, the inflammatory markers like IL-1 beta, IL-6, CXCL10, TGF-beta, and the extracellular matrix markers like collagen A1, collagen A4, PXDN were upregulated, also with higher oxidative stress, and the Wnt pathway and the SOX17 gene, which is known to modulate the wound healing and which helps in the normal wound healing, were downregulated, suggesting that pre-existing inflammation can lead to altered wound healing and altered signal transduction. What we found in our model, summing up our results and what did our model reveal and what is the normal and abnormal healing pattern, we created this graph in which after any injury or surgery, there is a pro-inflammatory response which starts, which leads to formation of active keratocytes. Once these active keratocytes are formed, there is an initiation of the profibrotic phase. In this profibrotic phase, the keratocytes gets transformed into myofibroblasts, and in a normal wound healing pattern, this myofibroblasts in presence of fibronectin undergo apoptosis, and it leads to normal healing pattern with no haze. However, if there is higher inflammatory markers present, or if there is any altered wound healing present, there is more activation of keratocytes. This more activation of keratocytes leads to excessive formation of myofibroblasts. When this myofibroblast formation is excessive, they don't apoptotize the way it has to, and in absence of fibronectin, they convert into fibroblasts, leading to aberrant collagen and haze. We used mitomycin in our patients, but it did not work because the mitomycin does not act on the altered pathways which we found in our study. So we started looking at the literature, and we wanted to see, is there any other novel targeted approach which can be used to prevent haze and which can alter this pathways which was found in our patient epithelium. We went into the literature, and vorinostat has been used, is a FDA approved drug and is used in cancer patients, and it works on the same pathways Wnt and NFKB, and it alters the activity. So we wanted to do the same. So vorinostat is an histone deacetylase inhibitor which has anti-inflammatory and anti-fibrotic properties, and it has a significant role in wound modulation. Dr. Rajiv Mohan et al. And his lab has worked extensively on vorinostat and its effect on PRK haze pathways. So we collaborated with them to do further tests and results on animal model. 36 rabbit eyes underwent PRK procedure for different grades of myopia. After excimer laser, there was application of either balance salt solution or mitomycin C 0.02% for 2 minutes, or Saha drops 24 microns according to the randomization. What we found on clinical examination at 4 months was Saha performed equivalently to a mitomycin C in reducing the haze, suggestive that it has optimal outcome. Doing a specular microscopy on these patients, we found that the endothelial cell count in Saha did not reduce over time over 4 months, whereas there was some amount of endothelial cell loss which was noted in mitomycin C, suggesting that Saha is a safe drop. Coming to what we found in the patient cornea was, however, Saha had less collateral damage. When you see this image, there is no loss of cellularity or keratocytes seen in Saha, whereas in mitomycin C there is loss of cells and keratocytes which we note, suggesting that Saha can be an efficacious drops. So mitomycin C, which did not work in our patients, Saha worked on the same cohort, suggesting that it can help us reduce haze. To conclude, it was unknown that pre-existing inflammation can drive haze. Also, novel biomarkers of haze can help in potential role in pre-op diagnosis and its management. Mitomycin-resistant haze can be due to altered molecular pathways, and Saha drop can be used for mitomycin C-resistant haze with less collateral damage. Future directions will be identifying this altered pathways and inflammatory markers with a clinic-based diagnostic kit, and customizing the treatment of PRK procedure either with mitomycin C or vorinostat. Right now, we are in a phase where we have collaborated with a pharma company to reconstitute the vorinostat Saha drops, which will be followed by larger clinical trials and clinical use. Thank you.
Though good presentation, but please tell me, you conducted the study on rabbits or human beings?
No, the first part of the study was done on the patient epithelium. During the PRK procedure, the epithelium, instead of discarding, we had stored it in a biorepository. After 6 months, when those patients developed haze over time, we went back, collected the formed those epithelium and did the gene expression study. The second part of the study was done on rabbit models. It is not yet done on human eyes because we don't know whether Saha will work on human eyes or not, so we can't just go there. So the stepwise approach is first to do an animal model, then cell line, and then the human trials. So we are right now in a stage where we have completed the animal model study and the cell line study.
So you plan to do on human beings
Yes.
also?
Yes.
Okay. How did you find out the myopic rabbits?
No, there is nothing
said
like
they were myopics.
No, the rabbits are there. We treat them for different grades of myopia, irrespective whether what is the eye condition. Different grades of myopia is treated: 3 diopters, 6 diopters, 9 diopters.
Okay, rabbits were not myopic.
No.
You said the myopic rabbits.
No, different grades were treated. Different grades of myopia were treated.
Thank you. The next presenter is Dr. Samrat, visual outcome outcome after cataract surgery in eyes with the corneal graft.
Good afternoon, members on the panel and colleagues. I'll be sharing my experiences of cataract surgery after a corneal graft. So basically there are three scenarios. If you have significant cataract with a corneal non-infectious disease, then you actually do a cataract surgery, combine it with keratoplasty, and that's known as the combined or triple procedure. And if you have minimal cataract, then you tend to defer the cataract surgery. And in any cases of infectious corneal disease, even if there is significant cataract, the surgery, the cataract part is to be deferred because you don't want to open up the lens. And there are very few studies that have actually seen the outcome of cataract surgery following PK in India. And we know that the indications for keratoplasty are different in India compared to the West. And we know that the outcome of keratoplasty is linked to the etiology. And because we have a lot of corneal scars, the etiology is poorer than the Western literature. And there is always a debate whether if there is cataract, we need to do a triple procedure or a sequential surgery. So the primary aim of the study was to report the visual outcome after cataract surgery post-PK, that's sequential surgery, and to compare the visual outcome with patients that have undergone a triple procedure. So this was a retrospective comparative case series between 2005 to 2016, and we included all patients who had undergone a sequential surgery and patients with triple procedure, excluding those that had less than 1 year of follow-up, and in those keratoplasties where therapeutic keratoplasties where a cataract surgery was inadvertently done. So the study variables included uncorrected and post-corrected visual acuity and the refractive status and intraoperative and post-operative complications. All the visual acuity measurements were taken on a logMAR visual acuity charts, and we converted visual acuities that were less than 20/200 according to previously published reports. And we carried out comparative tests between these two groups and also between within each group. So of total 489 corneal grafts, we had around 114 where cataract surgery was done. That included 81 triple procedure and 28 sequential procedure. But for analysis, we had 73 for triple procedure and 24 for sequential procedures. In both the groups, the gender and age groups were comparable. And if you look at the type of keratoplasties that were done for sequential, we had more of therapeutic PKs than optical PKs, and more of phacoemulsifications than extracapsulars. In sequential, in one case, we couldn't implant a lens, whereas in triple procedure, in 7 cases, no intraocular lens was implanted. If we look at the uncorrected and post-corrected visual acuity, we find that the visual acuity improves from 20/500 to 20/40 and 20/80 uncorrected and 20/40 best corrected at a mean time duration of 3.1 months. But it reduces to around 20/200 uncorrected and 20/100 corrected by the last follow-up, which is a mean of 27 months. If we compare in sequential surgery, if we compare the keratoplasty compared with the type of corneal grafts that had been done, we find that the visual acuity is slightly better with the 2032 with the therapeutic grafts compared to the optical grafts. And if you look at the type of cataract surgery that has been done, there is no significant difference between whether the cataract was removed via phacoemulsification procedure or through a extracapsular procedure. If we compare the sequential and triple procedures, we find that the visual acuity achieved in sequential surgery was significantly better than that achieved after the triple procedure. That was both in cases of uncorrected visual acuity and post-corrected visual acuity. And if we look at the refractive status, we find that except for the cylinder power, there was the spherical power, the spherical equivalent was not significantly different between the sequential or the triple procedure, with the triple procedure having less cylinder. If we look at again the number of patients that have obtained best corrected visual acuity of 20/40 or better, the sequential surgery had a better outcome compared to the triple procedure. We had certain number of complications, but regarding the difference between both these groups, they were not significantly different, except for graft infiltrate, which is quite a common complication that we encounter after any penetrating keratoplasty in India. So if you look at our study and compare it with literature, there are lots of published reports from Western literature. We find that our final best corrected visual acuity in the triple procedure is significantly less than that, and we have a very large, longer follow-up of around 52 months compared to what's that's been published in literature. If we look at the refractive status, we find that there's a better visual outcome in sequential surgery and higher cylinder power in sequential surgery, because most of these were therapeutic PKs. And although in literature they have found that there's not significant difference between sequential or triple procedure. Graft clarity, our graft clarity results in India is significantly less than that compared to the West, and because of the etiology as I discussed before. If you look, we find that the visual outcome following sequential surgery can be encouraging. The type of corneal graft or method of cataract extraction is not influential on the outcome, and graft clarity is dependent on post-operative events. Thank you.
Yes. What was the gap between the keratoplasty and the cataract surgery in sequential ones?
That was approximately, it ranged from around 3 months to a year or more. We waited at least for 3 to 6 months before performing a cataract surgery after a PK.
Okay. And you followed up some patients for 52 months also?
Yeah.
Okay. So in the sequential ones, what about endothelial decompensation?
Because we didn't have a specular to start off with at the initial stage, we don't have a specular count. But we have had primary graft failures. I can show you this thing. We had graft failures in both the cases, but to actually attribute it to cataract surgery, like we couldn't, because we didn't have a cell count beforehand, we couldn't do that.
Right. Okay.
Quality of the donor corneal graft, that is very, very important. The state of the endothelium.
Yeah, because in the sequential surgeries, of course, the grafts, that the quality of donor tissue that we use are not great. But even in them, those that survive the initial insult of the infection, and if they survive for 3 to 6 months, and if you take proper precautions, in a significant number of them, you can still get away with good vision. So it is not a very dismal thing. We had more therapeutics for sequential, understandably, because we don't operate the cataract if there's significant cataract at the time of therapeutic PK. But even in these cases, you can still get a good amount of vision. So a cataract surgery should be done even in these cases first. And if it fails, then you can of course go in for any other corrective resurgeries.
Any comment from the audience?
Which technique of biometry you follow in sequential cases?
Yeah, so in sequential axial length, we tend to keep it with the same eye. The keratometry varies. We tend to this thing what we call use the other eye as a guide, and also do measure the same eye. If there is significant difference, then we'd like to consider and presume that the other eye keratometry is more closer to the original one. But we haven't got, and so we take the keratometry values of the other eye. Even by doing that, if you see in the results, the spherical equivalent is not significantly different between the two groups. So you can take the other eye keratometry and then do it.
Effective K from topography can be taken?
Topography from the graft?
For the keratometry, yeah.
Not required. You don't need to do the topography from the graft. You can do it from, you can do a simple keratometry from the other eye. The graft topographies are usually, it will come out very weird because of the effect of cylinders and the surface changes. So I would recommend that you stick to simple keratometry. Thank you very much.
If his presentation is not ready, we may call the next speaker. Yes, please.
A very good afternoon to all of you. Myself, Dr. Alok, and I am presenting on a topic interstomal keratopigmentation, or in a very simplified language, it's a corneal tattooing. None of the financial disclosures. Let's introduce with the corneal opacity. It's really a social stigma. Therefore, to disguise the disfiguring scars day back in the 1st century with the Galen, he was also using intrastomal keratopigmentation. Keratoplasty might not have been a good option in every patient, either due to a poor visual potential or a good vision. Therefore, the indications why we are using the ISKP were to enhance the cosmesis of the eye for the optical purposes, also to improve the visual performance, and in the cases of cosmetic contact lens intolerance. What were the side effects that leads to the traditional metallic salts? They were not used. Due to the corneal erosions, recurrent redness and watering as they were acting as an irritant, corneal melting with the potassium, with the platinum salts, and also for the re-tattooing that were needed due to the patchy depigmentation. Therefore, a newer organic micronized pigment has been introduced for the ISKP. The aims and objective of my study was to improve the cosmesis and the visual disturbances, and also to compare the effectiveness of different techniques of corneal tattooing, that was the needle puncture, microkeratome assisted, and the combined. 43 patients were collected from the cornea clinic in my department from the Kanpur. The median age of the patients were 23. All were informed and consent were taken. Unfortunately, 2 patients lost to follow-up, so 41 were finally included in my studies. They were followed up for 1 year, and a set of 10 questionnaire was given just to assess their satisfaction level. In my inclusion criteria, there were the blind eyes, the patients with the no visual recovery like the amblyopia, squint or posterior segment disease, the patient with eccentric scar, and the corneoiridic scars. The patient excluded were the central corneal opacities, thinned corneal opacity less than 300 micron, or with the lid deformities, and the patient that were not obviously participating. So finally, we had the 27 patients that were underwent for the needle puncture, 13 underwent for the microkeratome, and there was one unique patient having a thick anterior capsular plaque with the distorted pupil leading to visual disturbances, underwent both the procedures. In the needle puncture ISKP technique, we were using a 26 gauge needle, and we were making a multiple stromal punctures without the epithelial debridement, and then there was the distribution of the pigments on the epithelium. In the microkeratome, we had a 15-number blade. An incision was made on upper border of corneal opacities. Then we were dissecting a lamellar pocket, and then pigments were used for the uniform distribution with the help of fine iris repositor, and finally, sutures were done. The patients were post-operatively tackled with the antibiotic steroids, and they were followed for day 1, first week, first month, and 3 months. This was the demographic profile of the patient. In this, we can see that first of all, we were using a lamellar pocket dissection, and after the lamellar pocket dissection, it was done with the help of the incision, and we injected OVDs to make a lamellar plane so that it can be uniformly put on the whole surfaces. After the lamellar dissection, we just used a dye with the help of a blunt iris repositor, and the important thing that we were making the note that there should be limbus to limbus distribution of the dye for the uniform distribution, so that the patient would not be having a problem later on. Just in the result and discussion, the 13 patients from the microkeratome, 27 by the needle puncture, and the 1 of the combined procedures, the post-operative follow-up was having a good result with the microkeratome assisted ISKP. In which most of the symptoms it resolved within a first week, while in the needle puncture technique, the most of the symptoms were persisting for 1 month. One patient had the symptom till the first year. Therefore, all patient had mild redness on first post-op day, lacrimation was more with the needle puncture, and the most problem resolved in 1 month. Patchy loss was seen. This is a case of needle puncture ISKP, 2-week post-op, and we can see that it was having a good uniform distribution. The same patient had a result immediately after a surgery. In the slit lamp, it was not having a good result, but if you see on the diffuse light, the uniform pigmentation was seen. This was the patient of the microkeratome assisted ISKP, and she gave a very good result. There was no chances of any irritable eye, as we were seeing in the needle puncture technique. In the combined surgery, it was also more or less equivalent to the needle puncture technique only. This was the patient having anterior capsular plaque with the pseudophakic eye and the superficial corneal opacity, and we underwent both the technique, needle puncture and the microkeratome assisted, and the patient was having a very good result. In the satisfaction level, the needle puncture was not showing a good satisfaction as with the microkeratome, and most of the patients were having a good result and they were satisfied with the microkeratome assisted. Therefore, to conclude, ISKP with nude pigment is very safe, satisfactory. Microkeratome assisted ISKP gave a good smooth surface and extremely satisfactory results. No re-tattooing was seen with the microkeratome, as with the needle puncture ISKP was requiring one or more settings, and it's a very cost-effective technique, and the patient with corneal edema might not have a good results. Thank you for giving your precious time.
Recommend which technique do you think should be used by all of us?
Ma'am, it was decided basically on the types of the corneal opacity. So in the corneal opacity, if we were getting for the superficial corneal opacities, so we were doing a stromal punctures. That was quite, patient was having a little bit discomfort for a first month or 15 days, but there was not more penetration in the cornea. So I would recommend for that.
And how long did this persist? I mean, the pigmentation just wore off with time or no?
Now, if you are going with the lamellar pocket, it has been persist.
In the needle puncture.
In the needle puncture, it was more than 6 months. After a year, we were needed a re-tattooing. For after 9 to 10 months, we were just willing for a re-tattooing. But
and
till
this
6
dye
months.
is still available? This
Yeah,
dye is still available?
Yeah. We are just asking the dye from the Mahatma Eye Banking from the Nagpur, and they are just providing this dye.
Okay.
Thank you.
Because recently it went out of market, I think. You are still using it?
Yeah,
Okay.
we are using it. Okay, thank you.
Good afternoon, everyone. I'm Dr. Madhu Manjri. I'm here to present the study which was done at Rajan Eye Care, Chennai. The aim of a study was to compare the outcomes of CXL, topo-guided photorefractive keratectomy with CXL and Intacs with CXL in the management of keratoconus. The objectives was to assess the difference in the pre- and post-operative uncorrected and best-corrected visual outcomes, sphere and cylinder, the topographic keratometric values including steep K and flat K, and topographic astigmatism. It was a prospective, non-randomized, comparative and interventional study. We included 52 eyes in the study. The inclusion criteria was clinical and topographic evidence of keratoconus, corneal pachymetry of more than 400 microns. For patients who had low astigmatism of less than 2 diopters, we opted to do only corneal collagen cross-linking. Patients having moderate astigmatism of more than 2 diopters, but less than 5 diopters, we did PRK with CXL for them. And patients who had high astigmatism of more than or equal to 5 diopters, we included them into Intacs with CXL group. Exclusion criteria: history of previous corneal surgeries, corneal pathologies like corneal dystrophy, concurrent infection in severe dry eyes, history of collagen or autoimmune disorders, pregnancy or lactation during the course of study. Each patient underwent UCVA, BCVA, manifest refraction including sphere and cylinder, pachymetry, IOP measurement, topography for steep K, flat K and astigmatism, slit lamp examination and fundus evaluation. After the initial evaluation, according to the inclusion criteria, each patient underwent the respective procedures. Patient who underwent accelerated CXL, that is 1% riboflavin drops for 30 minutes, followed by UVA irradiation for 10 minutes, were placed under group 1. Those undergoing PRK with CXL were placed under group 2. And those patients who underwent intact segment insertion with CXL were placed under group 3. So post-operatively, all the cases were followed up for the first few days till re-epithelialization of the cornea, and then on the first week, first month and 6 monthly, and then evaluated for the same parameters. Group 1, that is the CXL group alone, had 18 patients in it. Group 2, that is the PRK group, had 17 patients, and group 3, Intacs group also had 17 patients in it. This is the map showing the change in UCVA and BCVA pre and post procedures. The blue line indicates the CXL group, the red line the PRK group, and the green line the intacs group. As this is the baseline which shows the 0 logmar units. The blue line has shown a drifting away from the 0 logmar units in both UCVA as well as BCVA, indicating a decrease in the visual outcomes in the C3R group alone, whereas the intacs group and the PRK group are approaching towards the 0 logmar units, showing that there was a good improvement in the uncorrected as well as the best corrected visual acuity. As I had already discussed, it is important for us to note that the decrease in the best uncorrected visual outcome has been significant in the C3R group, whereas in the best corrected visual acuity was not significant and it was only by chance. But the improvement in the uncorrected and best corrected visual outcomes of the PRK as well as the C3R group, intacs with C3R group was significant as indicated by the P values. The change in the sphere, all the three procedures reduce the spherical value to a good extent. On coming to the cylindrical value, the intacs group as well as the PRK group reduces cylindrical value, but the C3R group alone had a mild decrease in the worsening of the cylindrical value. On seeing both the graphs, you are able to see that the steep reduction of the values was done by the intacs group. On studying the effectiveness of the sphere, it showed that although all the three groups reduced the spherical value, none of the three was significant. And on comparing to the cylindrical value, except for the PRK group, the other two groups had a good reduction. Change in the steep and the flat K. All the three procedures showed a good reduction in the steep and flat K, with the intacs being the best among the three, with the steep reduction in the first week itself. Studying the effectiveness on steep K, all the three procedures had a good significant reduction in the steep K, whereas the PRK group alone had an insignificant reduction, whereas the other two, that is the C3R and the intacs group, had a significant reduction of the flat K as well. Coming to the change in the topographic values, all the three procedures showed a good reduction in the topographic astigmatism, and the effectiveness was also significant. I've put up some of the topographic pictures of patient who underwent C3R and the other procedures. This patient who underwent C3R had showed a mild change in the topographic value, but this refraction was not of much change. Patient who underwent PRK with C3R showed a good change in the topographic maps, and the refraction also had a good change from which came to plano power and planospherical value and a -3 cylinder. Intacs patient who showed a remarkable change of topographic map as well as the refraction value, where the cylindrical power reduced from -9 to -2. So my conclusion is that the topographic parameters of CXL showed a good improvement, but the visual acuity and the manifest refraction was not of much promising. PRK with CXL and intacs with CXL also showed remarkable corneal topographic outcomes by flattening the cone and improvement in the overall shape. Therefore, I would conclude that intacs with CXL appears to be the most promising procedure among the three in improving all the parameters, chronologically followed by topo-guided PRK with CXL, and last being CXL alone in the management of keratoconus. Limitations: our study was only for 6 months. A longer follow-up period would have had a better assessment of safety and efficacy. Our study sample was only 52. A larger sample size would have added more statistical power to the study. And then last, the dividing the patients into groups according to their cylindrical power did not match the patients for an exact comparison in the improvement of the parameters between the groups. Thank you. Yes, sir.
Thank you.
Yes.
Next is Dr. Pawan. Is he here? Dr. Pawan? No, he's not here. Then Dr. Dipali Singhal. She is also not. Dr. Dipali. She was there in the morning. She left. She was there in the morning. Any speaker left? Or anybody who has come late? No.
These two are also not there. No? This one is also not there.
Thank you. So, thank you very much, everybody. And okay. The results will be displayed on the scientific committee office after a short while. So thank you very much.